Laura. I'd like to actually start by welcoming everybody. So thank you very much for joining us. I see from the chat that there are actually a number of international participants. So thank you and welcome. I also wanted to start by thanking Charlene Waldman, Michael, and Laura for really this invitation and this opportunity to tell you a little bit about FOP and what we have been doing in that area, as well as what other clinicians and other groups have started to think about what the best strategies for diagnosis and management are for FOP. All right, so I'm going to start by sharing my screen here. All right. So, oops, excuse me. Sorry, my apologies. Okay, so let me see. Okay. Oh, and it's frozen, of course. My apologies. Hang on a second. All right, so while the slides are loading up, what we're going to do today is actually discuss a little bit about FOP. We're going to talk a little bit about the clinical aspects related to the presentation of FOP. And then I have the pleasure of having two people from our group here at UCSF. So Kelly Wentworth, who is a junior faculty member, and Suki Singh, who is one of our senior endocrinology fellows. And they will help with some of the discussion about the cases that we'll have today. So let me try sharing this one more time. Okay, so hopefully this will work. Okay, are people able to see the screen? I think, Michael, you can just let me know if that's not working.
Yes, we can.
Looks good.
Okay.
We're in good
Excellent.
shape. Thank you.
All right, so thank you, everybody. Okay, so just very quickly, some of you may have seen the disclosures that I have. I have a number of them. One of the things, none of these actually pose any conflicts for this presentation. In addition, as Laura had mentioned at the beginning, this presentation is geared towards health professionals. Presentation does discuss the off-label use of some FDA-approved medications for the treatment of FOP. But because FOP is so rare, please keep in mind that treatment strategies need to be discussed with either experts, if you can reach out to people with experience with FOP, but certainly discussed in detail with the patients. And obviously, medical judgment is really important. For the patients on this call, welcome. It's really a pleasure to have you as part of this. I would really recommend that, if you have any questions, please discuss them with your physicians. You can reach out to me later on if you have any questions, but please do not initiate any sort of changes in your treatment plan until you've discussed it with your physician. All right. Okay, so I'm going to start with a very quick summary, actually, of the key points from FOP. And the first one is that if you see great toe malformations and migratory swellings, which we'll go through in more detail, this should raise the possibility of FOP as a diagnosis. And if FOP is suspected, you must avoid trauma and biopsies and any sort of things that might cause the potential for injury until the diagnosis of FOP has been ruled out. And I want to emphasize really trying to avoid biopsies. I will also add that routine medical care with things like peripheral IVs is totally okay. And that there are major medical centers that have expertise in FOP. Please reach out to any of us around the world. And especially if intubation is needed, we can provide a lot of guidance as to that. We'll have one case that talks a little about that. But the FOP, the IFOPA, which is the International FOP Association, or the FOP ICC, which is the International Clinical Council on FOP, have a listing of sites and different contact information. So, all right. Okay, so also, since I know this is recorded, this is a list of some of the references that are probably the most useful. The first one is the treatment guidelines. This is a peer-reviewed consensus guidelines from 21 centers from across the world. That is by far, that is sort of the treatment Bible, as we joke about it. But it's one of the best resources for actually getting information about management of FOP of all different aspects. And then these are the websites for some of the other resources. Okay, so we're going to start with a case. So let's start with a 5-year-old girl who was product of a normal conception and birth. And the parents started to report that she had restricted joint movement over time. There were migratory and intermittent swellings that were occurring. These started out at about age 2 or 3. And these were the great toe malformations were noted at birth. I don't have the picture of her toes at birth, but these were pictures at age 5. And what you can see is that there's some shortening and there's some sort of abnormalities here. Okay. So when you start to hear about these types of situations where there is a great toe malformation and then these sort of weird migratory masses that sort of come and go, sometimes they're firm and hard. This is a photograph of her back. And what you can see is that there's this extra lump that is kind of present that is not present on the left-hand side. That needs to start raising the possibility of FOP. And one thing to note is that pain in children, as with most other musculoskeletal disorders, is often extremely variable. Oftentimes they present with malaise, with other types of symptoms, but you may or may not actually get pain. Differential diagnosis for FOP should include things like infection, oncologic causes, so osteosarcoma, soft tissue sarcomas, desmoid tumors, rheumatologic causes like lymphedema or juvenile fibromatosis. This is especially true if a biopsy was accidentally done. It often comes up with features that look like a fibroma, or heterotopic ossification. So not only FOP, but a related condition somewhat called POH, or progressive osseous heteroplasia. This is actually caused by a different type of mutation and different pathway, but also presents with a diffuse heterotopic ossification phenotype and non-hereditary or acquired heterotopic ossification. But the key thing in all of this is that the presence of toe malformation is really helpful for really ruling out above. Okay, it's not completely perfect, but it is something that can be very helpful. The gold standard is essentially genetics for the ACVR1 R206H mutation. This arginine to histidine mutation is found in close to 97% of FOP patients. And so this is a highly sensitive, highly conserved genetic change that can be used for the diagnosis. And as mentioned earlier, you need to avoid trauma, things like avoiding IM injections, really until the patient is evaluated, and holding off on biopsies because that can actually trigger more bone formation. So this is a relatively famous picture, a series of pictures about a boy who has FOP. And over time, at birth, it was noted to have great toe deformities, which is here. But as you can see, over time, there's progression of the deformities and the heterotopic ossification in FOP. The disease affects between 1 and 1.4 to 2 million people, depending on the study that is used. There are recurrent flare-ups that are often associated with injury, but not always associated with an identifiable injury. There's ossification in muscle, tendon, and cartilage, and there are no effective treatments except really to try to avoid injury as much as possible. So there are a few key characteristics about FOP. The malformed great toe. Sometimes patients also have a malformed thumb, so shortening of the thumb. They may have complicated births, such as things like a subgaleal hematoma or head swelling. These can be especially associated with situations where assisted delivery was used. And in childhood, they often have decreased crawling, difficulty lifting the head. They don't really like, tummy time, so being on their abdomens, because they have difficulty actually raising their head. And there are these reports of intermittent lumps and bumps. And flares often start around age 2 or 3, but like other diseases, maybe earlier or later. So we keep mentioning this thing about toe malformations. And so this is a X-ray of a patient with FOP. And what you see is basically it's a first digit malformation. It's essentially loss of the joint over here. And this type of, the shape is not always consistent. Sometimes it looks like a bunion. Sometimes it looks like other types of features. But when you do the radiology, you will almost always find that there is a malformation that is present. The other aspects that are commonly seen in FOP patients are bridging heterotopic ossification, particularly within the cervical spine. There can be these elongated cervical bodies that appear to be present. There's no clear functional consequence from that, but oftentimes this is the initial presentation where we will hear about patients who had difficulty moving their head or neck stiffness, and you see this ossification. And then osteochondromas. So osteochondromas can happen anywhere in a patient with FOP, most commonly, at major joints. Pretibial osteochondromas, obviously this was one in the wrist. Those types of osteochondromas can often be identified. Okay, so when we talk about patients with FOP, we talk about those back swellings or migratory masses. And it turns out that these are very variable. So you saw the picture of the 5-year-old a little bit earlier, where it was a relatively flat kind of prominence. And if you were in a hurry or you're doing telemedicine and there's someone who's holding up like a cell phone photograph, you might not see it at first. But it's useful to take a look at the spectrum of these soft tissue swellings. So on the left-hand side here is a 9-year-old boy who had a very minor injury. This was just sort of like a very minor injury to the right scapula. And you can see that within a couple of hours, there's this huge mass, which looks like a golf ball just underneath the skin. It's red, it's indurated, it's painful, it's swollen. Here's another child where you can see that there's this mass that's present over here, but there's also a second mass up here on the left scapula. And this one is the one on the left is actually an older lesion that has matured, and this is the active lesion. If you were to feel it with the back of your hand, it would probably still be sort of warm to touch as compared to other portions of the body. But this doesn't have the same degree of redness that you would have seen in some of these more active flares that are present. So it's useful to keep in mind that the presentation of the FOP flares can actually be rather variable. So these flares can actually occur without obvious injury. So typically patients report swelling, pain, and erythema, sometimes warmth that is present. In children, it often starts in the axial regions, and then in teens and adults really starts to shift towards the appendicular. So this is a 2-year-old. You can see has multiple heterotopic ossification lesions. These are all relatively active. There's not much erythema, but they are, again, probably warm to the touch. And these flares can lead to bone formation. The challenging thing about FOP now is that not all flares result in bone. Not all heterotopic ossification was preceded by a flare. And the reasons for these differences are really unknown. Also, flares can be migratory or subtle, and as you've seen from the other photographs, so it's not always easy to tell sometimes, especially at the beginning when the flare is just starting up. All right. So over time, the cumulative result is that you end up with this on the right-hand side. Is that this is Harry. He is actually this skeleton is located at the University of Pennsylvania in the Mother Museum, and what you see is that this is essentially a second skeleton. There is just too much bone that is present. There's the primary skeleton underneath, and you can see the spine and the ribs and the skull, but there's all of this other heterotopic ossification that occurs. And this bone is essentially a second skeleton. It has the ability to remodel. It can fracture and heal. Some of the bones will actually end up with bone marrow that's present. So what it is really a second skeleton superimposed on top of the primary skeleton. As I had mentioned before, people have been very interested in FOP. The mutations, about 95 to 97% of the patients have this highly recurrent mutation, the 617G to A, which results in arginine to histidine mutation at amino acid 206. There are a number of other variants that have been described, but pretty much they're all in ACVR1. And this is a mutation that occurs in the glycine and serine-rich region. It leads to altered activity of the ACVR1 receptor. So there's increased constitutive activity, but also abnormal signaling activity, which we'll talk about. So the receptor itself is ACVR1, is in a complex with the type 1, type 2 receptors, and these actually bind to bone morphogenetic proteins. And they signal down through the SMADs. And one of the features about this particular mutation is not only does it increase constitutive signaling through the SMADs to increase BMP activity, it actually causes the receptor complex to misinterpret activin A as a BMP. What's intriguing is that the ACVR1 receptor complex also signals through other pathways, including P38 and also the NFkB pathways. And these become important because these pathways are probably important for monocyte and macrophage activity. And so we have additional resulting phenotypes that are probably result of non-SMAD signaling as compared to some of the other pathways, the more classical pathways that have been described. There's been a lot of research from a lot of different labs, and I'm not going to be able to go through all of that. But one of the things that we have been thinking about as to what the pathology or the pathophysiology of FOP is that you have this activating mutation that's present in the patient, and that there's some sort of primed innate immune system that has increased pro-inflammatory cytokines, sort of increased myeloid activity, and trauma, infection, some sort of event, which you may or may not be able to identify, actually results in an activation of this process. And you end up with a clinical flare that's highly inflammatory, as you've seen. You get these lesions. It may be responsive to steroids, which is the standard of care therapies at the moment. And again, we'll talk about that in a little bit. But ultimately, what ends up happening is that you end up with increased fibrosis, basically an inflammatory infiltrate at the site of the injury that eventually causes heterotopic ossification. And we think that a lot of this is because of activated pro-inflammatory or cytokines and chemokines, activation of the immune system by various different factors, causes inflammatory cell recruitment, and ultimately activation of some sort of tissue-specific progenitors. So the fibroadipocyte progenitors, or FAPs, are probably the cells that are most likely to be involved, but there's a lot of other information that suggests that multiple cell types are actually affected by this mutation and contribute to the heterotopic ossification. All right. I should also note that in other studies, what's been interesting is that cell fate instability seems to be a feature of the R206H mutation. And this was actually shown in a series of studies using human-induced pluripotent stem cells, where the ability to create the human iPS cells from fibroblasts of FOP patients was easier. And that's a rare finding. It's most of the time we find mutations that make it harder to make iPS cells. But in the case of FOP, the mutation does seem to make it easier to transition between different states. And since then, multiple tissue-specific cell types appear to be able to also lose their ability to lock in their cell fate. And it turns out can actually serve as the potential stem cells for heterotopic ossification. Okay, so what I thought I would do is just go through a couple of quick diagnostic pearls. Again, toe malformations and unexplained swellings. You need to really think of FOP until it's proven otherwise. If FOP is suspected, you have to avoid invasive procedures, so no biopsies or surgeries. The situations that we hear about sometimes, which are extremely challenging, are that you know, a child who age 2 or 3 is playing in the playground, has fallen, gets a bump on their head, they're not entirely sure what this is, goes to see the doctor, and then a biopsy is done, and then that trauma from the biopsy or the surgery actually triggers more bone formation. Those are the types of situations that we would really like to try to avoid. X-ray imaging can be extremely helpful. Stopping immunizations during this period of time while you're trying to sort out the diagnosis is important. And simple venipuncture blood draws. These are okay as long as it's done by an experienced provider. You don't want somebody trying to hunt down a vein, trying to, you know, sort of poke through. And certainly there's something about crossing the tissue fascial planes that seems to trigger worsened heterotopic ossification. So really making sure that you have an experienced team available is great. Heterotopic ossification and the skeletal malformations are the most obvious symptoms. And things like osteochondromas, so tibial are usually the easiest to palpate, but they're usually present at other sites. The malformed cervical vertebrae that we saw, fusions of the spine, this can sometimes resemble ankylosing spondylitis. And so we've had referrals come through saying it's like, well, this looks like AS, but it might not be AS. So we would like some thoughts. And then sort of the malformed first digits in the hands and or feet. And you should consider genetic testing for ACVR1, since that is by far the most useful in terms of the diagnosis. So treatments. So there are a couple of treatment pearls. The guidelines are the most up-to-date for the recommendations. And steroids can be used for severe flares in kids and also in adults. So the typical dosing is 2 milligrams per kilo per day of prednisone or equivalent. We usually do this for 4 days to try to calm things down, and then possibly consider a taper, since as with any steroids and other even non-FOP patients, coming off of the steroids can be challenging. It's important to start as soon as possible after trauma or a flare start, because it does seem to be that if you delay longer, that the ability to block heterotopic ossification or manage the flare does seem to go down. Avoiding trauma as much as possible is important. So things like non-elective surgeries, like ruptured appendix, those should go ahead. But other situations where you know, you can avoid things are great. So things like corrections of the malformed toes, you know, those types of surgeries we really try to avoid. If surgery is needed, there are protocols for giving steroids in the setting of surgery. Intubation can be extremely difficult and risky. It needs to be done by an experienced team. Fiber optic guidance is key. Immunizations can be given using a modified routes. So in most cases, converting the intramuscular immunizations to subcutaneous will work. Not in the case of tetanus, and certainly not in the setting of a recent flare, because it seems like the immunizations can actually also contribute. And there's emergency contact information on the IFOPA website for clinicians. You know, if there's any questions that come up, you know, please, you know, don't hesitate to reach out. All right, so as we think about therapies, one of the exciting aspects about FOP that there are a lot of investigational therapies that are out there. And I am not going to go through the mechanisms in a lot of detail, but this is all currently off-label use or investigational therapies. So there are strategies for actually targeting things like the inflammatory steps, the mTOR signaling, the HIF1 alpha pathway. So things like rapamycin, imatinib, anti-activin A antibody, IL-1 inhibition. There are efforts to try to target progenitor cell activation and sort of the bone formation process. So there are BMP inhibitors like the LDN using small interfering RNAs and saracatinib as an inhibitor. And also efforts to try to target things like chondrogenesis, sort of the later stages. So these are like the RAR gamma agonists. And then the long-term goal was really to do mutation-specific inhibition. If you can do something that is extremely specific for the ACVR1 activating mutations, that would be ideal and sort of the personalized therapy. And so a number of those therapies are actually also developed. Okay. So there are a couple of other important patient issues to sort of keep in mind. Quality of life is a major issue for our FOP patients. As you can imagine, many of them start out very functional. They're able to do all sorts of different types of activities, and they have this progressive, really unrelenting loss of mobility. Cognitively, they're pretty much completely intact. There's really no compromise of that. And so as patients get older, mental health is really a major concern. As they realize that they are continuing to function. School and work accommodations and adaptive devices are really important. I will point out that if you have a patient with FOP, the IFOPA is an excellent patient organization and really engaged to help with help getting these types of things together. And they are very well connected with the local FOP patient groups in different countries. Dentistry. This is a challenging problem. Partly because if any of you go to the dentist, you probably remember that you have to open your mouth for long periods of time, usually. What that does is that actually puts strain on the master muscles, and the strain can actually lead to a flare and locking of the jaw. Routine cleanings are generally fine. It's usually once you end up in the situation where a procedure needs to be done. And so making sure that you have a pediatric dentistry person involved early on is extremely important. That can be extremely beneficial for continuity of care. And one of the things that we've identified is that if you have patients who are adults, even referring them back to pediatrics because they have smaller tools, they can sort of squeeze in and clean things, that can be extremely helpful. But making sure a good dentistry team is involved is great. And I will add that the IFOPA website actually has a list of dentists with expertise in FOP. Physical therapy and occupational therapy, we try to limit the use of this, and it's active motion only because of the risk of injury. We'll talk about this a little bit more in one of the cases, but really the goal here is not anatomic correction. It's really for comfort of the patient and trying to prevent flares and any sort of progression. And then the last one I'll just touch upon really briefly is pain management. Pain is highly variable, extremely difficult to manage, especially during flares. We're not entirely sure why that is the case. There's some thought that this is actually related to the FOP mutation itself, but trying to make sure that the patient is comfortable can require the services of an integrated pain management team to really help out. Okay. Current research opportunities for anybody who's interested. Many of the FOP patients and their families are actually really engaged in this arena. So there are clinical trials, there are multiple companies, which I won't mention here. Extraskeletal manifestations are an aspect that we're trying to understand more. So these include like the GI and neurologic phenotypes. There are a number of investigator-initiated studies. There are multiple sites across the United States and the world who are interested and would love support. And just to let you know, we have a couple of studies at UCSF, including biobanking for different types of tissues, and we share those tissues for research purposes. We have interest in inflammation, the GI and neuropathic pain manifestations, as well as human disease in the dish studies. And I'll also, again, point out that the IFOPA, the patient registry and biobank, are really, really a centerpiece of a lot of the research that can go on. The patient registry is worldwide and has collected a large number of FOP patients and includes patient-reported data, and soon will include physician-reported data, as well as the IFOPA biobank, which also we participate in and allows the use of biological samples from FOP patients. Okay, so quick summary. Great toe malformations and migratory swellings. Sorry if I sound like a broken record, but that's the main thing that is really important to keep in mind. That needs to raise the possibility of FOP. If FOP is suspected, avoid trauma, and please contact a major FOP center for any sort of guidance. And there are different guides that are available through the IFOPA and the International Clinical Council. And again, the key resources that we had at the beginning. So I will stop here. I will just acknowledge a lot of people. These are collaborators that we've had the pleasure of working with, as well as my lab, both the wet lab as well as the clinical research side, that has contributed to some of the knowledge that's out there. And this is our contact information here at UCSF. If any questions come up, we're happy to serve as a, sort of a starting point and refer you to closer centers that may be able to also help out with things like FOP or FOP-related diagnoses. And one thing, just really quickly before I end, I do want to have a shout out to Amanda Callie and the Radiant Hope Foundation. And just for disclosure purposes, they have supported my research. There is a really nice documentary called Tin Soldiers, and this was an outreach project for trying to identify patients with FOP, particularly in third world countries. But if anybody has a chance to look at it, there's a short, I think a 12-minute video summary, which is really touching and really, I think, brings home some of the challenges about diagnosis. And there is a longer version that Amanda has been helping with the screening. So I'd strongly encourage people who are interested to take a look at this. So with that, I will stop, and I think I'm happy to take some questions before we launch into the cases.